Afternoon, everyone, and welcome to our NNN session entitled People Are Neglected, Not Diseases. I'm Sarah Martindale, a technical advisor for lymphatic filariasis and patient care in the Ascend West and Central Africa programme, based at the Liverpool School of Tropical Medicine, and I'll be moderating this session. Before we start, I'll just go quickly over some of the housekeeping points. So you will notice you have entered the workshop with your cameras off and audio muted. Please keep your audio muted to help keep background noise to a minimum. If you are invited to speak, please unmute yourself by pressing the microphone button in the bottom left-hand corner, and feel free to switch on your video again by using the button in the left-hand corner. During this session, we'll be doing some group work in breakout rooms. When it is time, you will be automatically moved into your breakout room by one of the MYT team. No action is required from yourself. Once you're in a breakout room, please turn on your video using the button on the left-hand corner. You may also unmute yourself when you wish to speak and participate. Kindly mute yourself again after you have spoken to avoid any background noise. Once group work is completed, you'll return automatically to the main room after a 60-second waiting period. Please do take note of your facilitator's name when you move into the breakout room. Should you become disconnected at any point, we can use this information in order to add you back into the correct breakout room. We ask you to then switch your video and audio off upon returning to the main room. If you wish to interact during this session, please use the chat facility on the virtual meeting platform. You'll find this by going to the Agenda tab in the virtual platform and clicking on your session, which you should have already accessed to reach this workshop. You can also use the chat function within Zoom. The MYT team are here to help you with any technical difficulties. Please use the chat facility on the virtual meeting platform to ask any technical questions, or email the team at admin@nnnevents.com, where the MYT team will reply to you immediately. And just to also let you know that this session is being recorded. So welcome again to our session, People Are Neglected, Not Diseases. Next slide, please, Carlos. And next slide again. So this session will examine the operational and contextual challenges in Leave No One Behind in neglected tropical disease programs. This session will share specific examples from the Foreign, Commonwealth and Development Office funded Ascend West and Central Africa programme. And the outcome of this session for attendees are to firstly raise awareness on the importance of embedding Leave No One Behind approaches into NTD programming to achieve elimination goals and to contribute towards the sustainable development goals. Secondly, to improve knowledge on the successes and challenges in operationalizing a Leave No One Behind approach in integrated NTD programming. And finally, to identify potential solutions to advance Leave No One Behind approaches whilst being aware of budgetary constraints. So as I've said, I'm Sarah Martindale. Next slide, please, Carlos. And joining me in this session are 5 speakers. Firstly, Tracy Vaughan Goff, who will be presenting on conceptualizing Leave No One Behind. Secondly, Dr. Carlos A. Torres Vitalas, who will be presenting on an introduction to Ascend and Leave No One Behind. Thirdly, Anita Guam, who will be presenting on examples of conceptualizing Leave No One Behind from Nigeria. Next, Dr. Peter Mapoma Mikobi, who will be presenting on examples from DRC. And finally, David Ajaman, who will be presenting on examples from Ghana. Following these presentations, we will break out into groups for group work and then end with closing remarks. If you've got any questions throughout the presentations, please do ask them using the chat function within the NNN platform or via Zoom. When submitting a question, please make it clear which speaker you are addressing your question to. Then following the presentations, we will ask these questions to the speaker or at the end of the session. Any questions we're unable to answer in this session, we'll be sure to answer afterwards. So our first presenter is Tracy Vaughan Goff. Tracy has over 20 years humanitarian and development experience working on disability, gender and protection in Africa, Asia and globally. She has worked for a number of UN agencies and NGOs and has been at Sightsavers for 6 years. Tracy provides the overall strategic technical leadership for Sightsavers programs on disability and inclusion and is responsible for a team that designs and manages programs on inclusive eye health, political participation and economic empowerment, as well as internal diversity and inclusion efforts. She also provides technical support on inclusion to the Sightsavers NTD department and led the development of the Ascend Leave No One Behind strategies. So over to you, Tracy.
Hello to you all, and thanks to Sarah for the introduction. So Leave No One Behind is a concept that's gaining prominence in the development sector, and it's fundamental to the Ascend West and Central Africa programme. We thought, therefore, a good starting point to this session will be to explore what the phrase means conceptually as well as practically. You will hear how we have applied the concept in Ascend, and you will also hear some country-based case studies. But before we get to the details, let's all get on the same page. So first, I'm going to unpick a little bit what Leave No One Behind means. So it is a concept that's been given additional visibility due to the Sustainable Development Goals, or SDGs. The Overseas Development Institute explained it very well, and I've picked out a few key points to highlight. Leave No One Behind is the central commitment of the SDGs. The outcome document states, and I quote, "We wish to see the goals and targets met for all nations and peoples and for all segments of society, and we will endeavour to reach the furthest behind first." So this is recognition that our societies are inherently unequal, that there are those amongst us who experience poverty, in many cases extreme poverty, and exclusion, whilst others may not. And this inequality can be attributed to a range of factors: societal discrimination, age, wealth, education or gender, for example, and the intersection of these characteristics. So Leave No One Behind is at its heart an anti-discrimination agenda, one that aims for a more equal society where the most marginalised can be supported to catch up with those who tend to benefit more. Is a contrast to the outdated trickle-down theory of development, whereby a one-size approach meets all needs. And this was a strong critique of the MDGs, that whilst there was a lot achieved in terms of poverty reduction, globally, various studies report limited development progress for the most excluded and the poorest. A Leave No One Behind approach, therefore, places those people who are most excluded at the heart of our thinking. It reminds us that not all people have equal access to services or are part of decision-making structures, and for that reason, their needs and interests can often be overlooked. And this exacerbates their exclusion and ultimately reinforces inequalities. Consequently, Leave No One Behind approach demands that targeted and proactive interventions are required, or progressive universalism, which means putting the last first. For that reason, Leave No One Behind approach forces us to conceive of strategies that will prioritise actions that will make that a reality. Next slide, please. But this is the concept. In terms of practicalities, what does this mean for programming? The key elements should be defined at a program implementation level because they will be context specific. And whilst we can make some general assumptions around certain groups who tend to be marginalised, such as internally displaced people or people with disabilities, circumstances will vary dramatically based on the context. So together with an understanding of who is the why. What are the socio-economic or environmental barriers that need to be overcome in order to effectively reach those people who are left behind? What strategies can be put in place that will be successful in ensuring we target the most marginalised first? Now, it can seem daunting, especially when working in a context where the vast majority live on or below the poverty line. And how do we determine who to prioritise? Well, even in the most poor communities, when you ask the question, you will be pointed in the right direction. And the important thing to note here is that we need to engage with the most marginalised to identify what their priorities are, as well as the policymakers, to work collaboratively on identifying the most feasible solutions. The process itself should be inclusive. In the disability movement, there's a phrase which makes a lot of practical sense: nothing about us without us. And essentially, people with disabilities know best their situation, what will work to include them. So the last point to note is that Leave No One Behind approaches will require commitment, both in terms of action, but in terms of budget. This may mean paying for sign language interpretation for community meetings, or it might mean training up more women health staff. The assumption is that more inclusive thinking being turned into practice will ultimately level the playing field for those who are left behind. And that can only benefit the communities where we work and ultimately the overall goals for sustainable development. Thank you.
Thank you, Tracy. I really like that phrase, nothing about us without us. We've got no questions at the moment for Tracy, so we'll hand straight over to our next presenter, which is Dr. Carlos Torres Vitalas. Carlos is a social scientist affiliated to the Schistosomyces Control Initiative Foundation since 2017. He holds a PhD in sociology and an MSc in research methods from the London School of Economics and Political Science. His expertise lies at the interface between human geography and public health, and his research interests focus on the links between socio-ecological adaptations to the environment, nutrition, and tropical diseases in South America and Africa. At SCIF, Carlos examines social cultural determinants of treatment uptake, equity issues within the NTD control activities, and the use of participatory approaches for health system strengthening. In addition, he is involved in the development of monitoring approaches to oversee community-based sensitization and behavioral change strategies. So over to you, Carlos.
Thank you, Sarah, and thank you, Tracy, for the presentation. It was very instructive. I'm here today to make a very brief introduction to the ASCEND program, specifically in terms of what we do in terms of Leave No One Behind. For the ones who are not familiar with us, first I wanted to mention that ASCEND stands for Accelerating the Sustainable Control and Elimination of Neglected Tropical Diseases. It's a program supported by the United Kingdom's Foreign, Commonwealth and Development Office. And this is a consortium of organizations led by Sightsavers, including others like the Liverpool School of Tropical Medicine, the Schistosomyces Control Initiative, Maud McDonald, and MC Sachi and Sachi. And we are there basically to support, provide technical support to the Ministry of Health in terms of ensuring that they implement their control initiatives for neglected tropical diseases such as schistosomyces, soil-transmitted helminths, trachoma, lymphatic filariasis, among others. We are based in 13 different countries in West and Central Africa, as you can see on the screen. And within this program, in terms of Leave No One Behind, as Tracy mentioned just now, we are mostly interested in proactively reaching out to the most marginalized groups in our respective intervention areas, ensuring that they benefit from prevention, diagnosis, and treatment activities for NTDs. In order to do so, the ASCEND adopted an inclusion lens. That means that we are aware that there are many different types of marginalized communities, but at the same time, it's not that the majority of them are in such a situation because they're actively excluded or discriminated by the society or by governmental institutions. Is that on many occasions, these are groups that are not part of the public agenda or the political debate. And in that respect, part of that implies that many interventions, many development interventions make assumptions about how to reach out to the deprived communities, and that results in implementing strategies and activities that not really match the needs and interests of the most vulnerable groups in our countries. In that respect, we are trying to actively do something about inclusion of these groups across three general areas of action. One concerns our services, what we do for a living on a daily basis in terms of mass drug administration activities, in terms of surgeries, in terms of sensitization campaigns, etc. And at the same time, we are making sure that our different services include an action concerning combating stigma and discrimination, both within the health system as well as the wider, in terms of the wider society, reaching out to communities as a whole, and ultimately making sure that our initiatives are formalized either in guidelines for public health or in policies associated to that subject. One element that I would like to stress is that within ASCEND, it's not that our central team decided that there was a specific strategy that all countries should adopt and implement. Instead, we adopted an iterative and learning process. We ask our country programs to think about leave no one behind, to analyze their own situation, and to develop their own strategies, kind of developing a bottom-up approach to this agenda. Country programs gather evidence and analyze the situation with regards to leave no one behind, thought about what could be done on the matter, developing their own work plans, and after that we are systematizing these strategies so as to make sure that these are operational activities that can be also monitored and evaluated, so that we adapt our programming to this interaction between country programs and our assessment of how to operationalize those initiatives. So that once we develop our own evaluation and different types of assessments, we learn again what went well, what could be improved, and we start the cycle all over again. And that meant for us working across 4 different areas in terms of health system strengthening, in terms of mass drug administration, morbidity management and disability prevention, as well as WASH and behavior change communication campaigns. So our different leave no one behind strategies have to cut across those different dimensions of action in terms of services, in terms of reaching out to the wider community, in terms of sensitization against stigma and discrimination, as well as trying to ensure that different policy and institutional guidelines are concerning those different 4 areas of action include our own reflections and thoughts with regards to leave no one behind. Thank you.
Thank you, Dr. Carlos, for that introduction to Ascend and how Ascend is considering Leave No One Behind in its programming. We've got no questions coming through at the moment, so we'll move on to our next speaker, Anita Guam. So Anita works with Sightsavers as a program manager and regional capacity building support for NTD programs in Nigeria. She has worked with the organisation for more than 10 years and has over 12 years experience of programme management in the design, planning and implementation and evaluation of NTD and eye care programmes in northern Nigeria. She was fully involved in the introduction and integration of community-directed tropical health interventions in Nigeria, and she has also supported the design, implementation and reporting on cross-cutting issues in programme delivery, particularly in FCDO-funded projects in Nigeria. So over to you, Anita.
Yes, thank you very much, Sarah. Good morning, good afternoon. Joining showing some of the practical approaches we use to ensure that is left behind. Carlos. So, for us in our NTD programs in Nigeria, we try to ensure that we ensure we targeted various groups that are likely to be left behind during NDAs. So I will show you practical approaches that we use and also some specific case studies of how we're able to attain that. So some of the ideas we did was to ensure that our, sorry, you can't hear me. Can you hear me? Hello?
I think it's just an issue with your microphone, Anita. The audio is just poor.
Can you hear me now?
That sounds much clearer.
Okay, sorry everyone. Can you hear me now? So
yeah, that's much clearer.
I was saying that I'm going through the practical approaches that we use to ensure no one is left behind in our programs. So initially, when the Leave No One Behind concept was not new, we had what we call hard-to-reach areas in our NTD plans. With the ASAM program and with the initiative of the Leave No One Behind, we are working to ensure that the concept is included in our NTD plans. And so what we do is, when we are working in a state, because each of the states in Nigeria, we have a different setup, different culture, we have to identify who and what kind of groups are likely to be left behind. And then the program plans to target them. And what we do is that we ensure these groups are targeted and they participate in MDA implementation from the beginning to the end. So we ensure that as part of our program planning, those various groups are targeted and they are part of the program training. And we ensure that any MDA activities that is happening, they are also part of it. For example, during advocacy, we ensure they're included, we ensure community sensitization is done to such groups so that they can also participate and also we hear from them their needs, include it in our MDA planning. And when we do that, we ensure they select their own community distributors who are being trained to distribute this medicine in those groups. And another thing that also helped us to promote Leave No One Behind is that we have a template for documenting what we have set out to do. And this helps us to track and ensure that those approaches are being implemented. And we ensure we monitor the process. Another good-ish thing is the beneficiary feedback. We use different methods to collect information from our treatment coverage surveys. We also use questionnaire forms during our impact assessments. We get information feedback from the community, and we're able to identify those groups that were missed out of MDA. And then we plan to include them in the subsequent MDAs. And another approach we are able to use is that all our data, MDA data, from the treatment to the trainings, they are all disaggregated by male and female. And we have also piloted disability indicators in our MIS, which is good for us to compare to see if we are actually reaching those vulnerable groups in our communities. But again, now with the recent complication of COVID-19, there is an implication, it has its implication for Leave No One Behind. It could delay our MDAs, or even some people could not reach because of the trend. Next slide, please. So I will show you some specific concept analysis that we did and how we were able to target some of these vulnerable groups. As Tracy mentioned in her presentation, the context is you need to do a context analysis, the how and the why and the who. So one example here is the who now is internally displaced person, and the how is conducting MDA. I mean, because of security issues in the area or even flooding, we found that these IDP camps happen in security challenge areas. And in the ASCEND program, we work in northern Nigeria, the northeast, the northwest, and the north central. And we know the kind of insecurity that we have, the issues we have around security. So you see our programs having a lot of IDP camps. So what we do is that we ensure we target these IDP camps. We plan with the stakeholders, the line ministries are involved in coordinating these IDP camps. We coordinate and plan with them, and we ensure that we implement MDA in these areas. An example of what we do is to, the way the IDP camps are, a lot of people, a lot of population, sometimes if you get 800 persons living in these areas. So you need to organize them. And what we do is we get key influencers in the camps who help us to conduct mobilization activities and sensitization activities. And then they select their CDDs, that's the drug distributors. We select them and then we train them to go and distribute and organize the camps and ensure everybody takes the medicine. And in terms of data collection, we have the community registers that we use, hard copies. So we have dedicated registers for this camp so that it will help us in our data coverage analysis. And in places where the whole state is endemic, for like river blindness, we won't have issue of nature problem when we are calculating coverage. Because even if people are displaced from one area to another, they are still moving to endemic areas. But in a place where not everywhere is endemic, you might have that issue. Where somebody moves to a non-endemic area, you have to go back to the previous data to check where the dent in population is. So this is just an example of how you could organize and conduct MDA camp. Next slide. The next slide, I'll show you another example of another context analysis that we did in the Fulani migrant locations. In the northwest, mostly northwest, northeast, we have the Fulani group, the nomads, and we had to target them. From one of our beneficiary feedback sessions during the treatment coverage surveys, we found out that most of these groups were missed out in the northwest area of Nigeria. And we found out why is this the issue. We found out that we have two majority groups, tribal groups, the Hausa and the Fulanis, and we found out that the Fulanis they have these trust issues. they will not accept medicine or food from another tribe. And we also heard that we normally use the measuring stick to measure during MDA. They told us that it's only dead people that you measure with a stick. So because of those issues, we had to target them and conducted mobilization, plan with them, and ask them to select someone from their own culture. And this is an example of Aminu. It's one of the citizens that we have that was trained to go back to his community and distribute MD. And because he's from them, they allow him to measure them, and they also take the medicine. And so we have now improved coverage amongst our Fulani nomads. Next slide, please. So another case study I want to share is how we're able to involve, disabled persons organizations and people living with disabilities in our programming. So we noticed that we have some of the persons with disabilities are missed out during MDAs. Maybe when you go to a household, they might not present. If you have a child with some form of disability, they might not want to present, or they'll feel that the medicine is not for that child. So when we create awareness, we meet these groups and engage and ensure they participate in our MDA activities. One example, the examples I have in this picture is, we have Sani, who is a very, very active chairman of disabled persons organizations in northern Nigeria. It's part of our planning, meetings, and NTD activities. It goes back to his association, hosts meeting with his members, and ensure that in every district, any community that they are, they should take up and participate in MDA activities when the MDA round comes. And so he does a lot of community mobilization, both for our MDA and also our mobility management and disability programs. It ensures that his people participate and they take up the services. You can see the second picture down is Collins. Collins is also a very active CDD. This is in central Nigeria in Benue. It goes around distributing the medicines and also conducting sensitization on MDA. So basically, these are some of the examples of how you could, the concept you could use on the Leave No One Behind, trying to engage different various groups with MDA so that no one is left behind. Like some of the key challenges and lessons we've learned so far is insecurity issues. We know that with insecurity, we couldn't even map some areas. And so those people that were not mapped, MDA cannot even come in those areas. And also it causes delay, and sometimes some areas is no go. So you have to devise means of ensuring that those people in those areas are treated. And then I mentioned that we tried to pilot disability data in the data collection tools that we have. But the issue is comparison. In Nigeria, we don't really have definite data for disability. So we couldn't compare to know, are we actually reaching those targets? The global figure is 15%, but that 15% has a lot of indicators. The age are included. But for us in the MDA, we give medicine to the age. So that 15% is actually not a true reflection of what is our real disability data in Nigeria. But a good learning is that the provision of a template to track the Leave No One Behind, our strategies and our plans, has helped us to actually make a way forward. So thank you very much for your attention. And I hope you have learned something from me. Thank you.
Thank you, Anita, and thank you for providing some really interesting examples of how you've operationalized Leave No One Behind in Nigeria. And thank you for the comments in the chat group around the terminology for drug distributors and how in India they're referred to as drug administrators rather than drug distributors. We'll now move on to our next presenter, Dr. Peter Makobi. Dr. Peter is a highly experienced medical epidemiologist and public health practitioner with over 14 years experience in a senior role within DRC's NTD program. He has a wide range of experience in the implementation of NTD activities, having been the medical coordinator for the Onchocerciasis Control Program in 2 provinces of DRC. And he currently serves as a program coordinator at the LSTM DRC office and is a SEND regional capacity builder. Dr. Peter will now present on his experiences from operationalizing Leave No One Behind strategies in DRC, specifically treatment of prisoners in DRC during MDA campaigns. From 2008 to 2016, Peter was a provincial NTD coordinator for Kasai province in DRC. It was during his time as provincial NTD coordinator that he identified that prisoners were a key setting to target in DRC. This is because in DRC, CDDs are not permitted to enter prisons, and as such, prisoners were missing vital NTD treatments and therefore at greater risk of developing clinical disease and morbidity associated with NTDs. As well as not receiving treatment, these prisoners are also at greater risk of these diseases due to the living conditions within the prisons. Although there's no prevalence data for NTDs amongst prisoners in DRC as such, it is acknowledged that by excluding these populations from NTD treatments, it affects not only the individual, but also the community they return to upon their release, impacting transmission of NTDs and preventing achievement of NTD control and elimination targets. So due to internet connectivity issues, Peter has pre-recorded his presentation, which we will start now. Thank you, Carla.
Welcome to the NNN Conference. I am Dr. Peter Poma-Miko, LSTM DRC country representative. Slide. Yeah, I'm going to present you some successes in the delivering MDA treatment in the Kananga prison in Kasai Central province in DRC. Before the implementation of this treatment in Kananga prison, some steps were carried out. Then we had some advocacy meeting with some partner, local chief and politic authority, meeting with local key stakeholders, sensitization of prisoners, MDA distribution in prison, and sustainability. But why we have chosen to treat prison? In Africa conception, prison is one who had done wrong or rubbish things, and then this one needs to be corrected. That's why he must be in prison. And then he doesn't need some treatment. Then this discrimination to those people cause them forgot for certain activity to be involved for them, such as MDA, as they are LNOB, as the same for others NOB people. That's why we have chosen to treat them. Because without treat this person, the elimination of NTD disease in DRC will not be our achievement. Going forward, the NTD national program in DRC aims to increase the delivery of MDA treatment to more prisons. Slide. We have been confronted to some challenge during this implementation. Difficulty to engage all key stakeholders, included in the MDA planning at zone de santé level, means something. Training of prisoner healthcare staff on MDA and SAES effect management, accurate population data. As you know, prison is more sensitive environment than to have population from prison director. Many question was in there. Then with what we will do with those data, and then many things, ensure sufficient tables are available, data tools collection. Even for these, how for MNE, how to calculate treatment coverage in prison. As you know, prison seems to be one entity in health center in zone de santé. Then how we may calculate the treatment coverage and some potential attitude barriers. As enter in prison, even during the visit, you need to have authorization or the approval from the director of prison, the provincial ministry of justice, the provincial ministry of security, police department, and municipality authorization. So it was very tough. But with the meeting with all state key orders, it came easily. Slides. We think to select 4 or 5 prisons in LSTM DRC supported zone de santé to pilot the distribution and LFK's funding in 2020 and 21 campaign. To conduct an advocacy and planning meeting with all key stakeholders from the provincial and national level. LSTM DRC will supervise MDA distribution in the prison and selected. Integrate the prison MDA distribution planning in the MDA planning meeting at the zone de santé level. Then some step needed: accurate population data and sufficient drugs. Integrate prison health staff with MDA training. Sensitize all stakeholders and community and prisoners to ensure the obvious side effect management and escalation processes for MNE and the surveillance. Work with the MO to establish how this strategy be escalated up across DRC. Slide. In conclusion, for the achievement of the objective of the elimination of NTD in DRC, not being treated as prisons, as they serve as a reservoir of disease. They need also to be treated and to benefit mass drug distribution like all others people. And then for this, so an additional effort in terms of finance and materials resources are necessary. Treating these people as others LNOB people, we hope to eliminate NTD disease in DRC. Many thanks for your generous sponsor and your support. Thanks a lot. Welcome to.
Okay, many thanks, Peter, and especially for pre-recording his session so we could overcome some of the difficulties with internet connectivity in Kinshasa. If there are any questions for Peter, please do enter them in the chat function and we'll make sure those are answered. Our next presenter is David Adjaman. David is a senior program manager for Site Savers in the Ghana country office and has 17 years experience in NTD elimination programs and led the eradication of guinea worm in Ghana in 2015. He coordinated the National Guinea Worm Interagency Coordinating Committee and the Guinea Worm National Certification Committee from 2010 to 2014. David also led the elimination of trachoma in Ghana in 2018 and in the design and implementation of post-intervention surveillance plans for guinea worm and trachoma. David is currently a member of the Ghana Inter-Country Coordination Committee for NTDs, the National Trachoma Elimination Committee, and the Ghana Onco Experts Committee. So over to you now, David, for your presentation.
Thank you very much, Sarah. And thank you everyone for this opportunity. So in this presentation, I will attempt to demonstrate how we can systematize Leave No One Behind practically in our projects using Ghana's example. The first step for systematizing Leave No One Behind in projects is to get a strategy in place. The second step is to get the required tools which you will use to operationalize the strategy. So in Ghana, we have our Leave No One Behind strategy. And what you have on your screen now are the key tools that we use. You can see that we have tools at each level of the project implementation. So at the planning stage, we have our financial request template. And this template is the template the partner uses to request for funding for activities they implement. And we have questions on this template so that whenever the partner is filling this template to submit, he will be reminded that this activity that you are requesting for fund for should include Leave No One Behind approaches. The second tool we use also at the planning stage is the Leave No One Behind implementation checklist. And this actually is a checklist which documents the various approaches, Leave No One Behind approaches that we have in our strategy. And it is supposed to be completed at the beginning of every program. It takes the implementer through a thinking process, asking questions such as, have you done analysis to identify people who are likely to be left behind? Have you included persons with disability in this activity, and so on and so forth? So the person is taken through a thinking process as he completes this checklist. At the training stage, we have designed a simple document. It's just one page. Because we are dealing with a national program, we can't be everywhere at the same time. So as training is going on at subnational levels, we have provided a brief information on Leave No One Behind, which whoever is doing the training at the various levels can quickly use to train the people on Leave No One Behind. During implementation, we want to find out whether this leave no one behind approaches are actually implemented. So the supervisors, we've developed a supervisory checklist which they use, and as they go around, there's a question that is put to the supervisor to check whether leave no one behind approaches are being implemented. And the supervisor is supposed to respond on the checklist whether this is being done. At the end of the activity, we have developed a narrative report and have a special space for leave no one behind, and the partner is supposed to report on leave no one behind. And this means that they always have to make sure that leave no one behind is part of what they do or they plan. Otherwise, they wouldn't be able to report for that session. Next slide, please. So I will now move ahead to explain to you one of our successes in Ghana. In 2018, we have a challenge in one of our districts, the Akuapem North districts. This district initially was thought to be non-endemic for onchocerciasis. But in 2017, when we carried out an impact assessment, we realized that it was actually endemic. It had high prevalence. So we decided to start treatment in that district. Treatment started in 2018. And as it's normally the case, because this was the first time of the treatment, many people develop adverse events after the treatment. And unfortunately, one woman died a day after the treatment. And people attributed her death to the ivermectin distribution. So the community where this happened, the Adokwanta community members became very angry, and we insulted health workers and CDDs, the distributors, and to the extent that the distributors actually decided that they were not going to continue the distribution. Unfortunately, community leaders in this community became campaigners against the distribution of ivermectin. The health directorate did everything they could, but the problem largely remained. So we decided to implement our Leave No One Behind approach in this community. Next slide, please. So what we did was that first we carried out context analysis. We wanted to understand what the issue was. Was it that people actually were not taking the drug because of the death of the woman, or was it something more to that? So together with the district health directorate, we brought the health workers and the various supervisors together, and then we tried to find out what the issues were. As part of that meeting, we also identified key persons in this district and also in the community, affected community, people who actually have influence to change the behavior in the communities. All those people who were invited were brought together, and we had a meeting with them and then explained to them the rationale for the treatment and everything that they needed to know about ivermectin and the MDAs. And we assure them of how committed we are to protect them using our safeguarding policy. So also we together with them, we tried to get them to identify how they can lead in getting the community to understand that the death was not actually due to the ivermectin, and that the ivermectin was safe, and that everyone needed to be involved in the MDA. So these community leaders, who included religious leaders, political leaders, and so on, we helped them to develop their own plans, and they went back and implemented the plans in their communities. And the results was that there was a change in these communities, so that the next MDA, actually we saw higher participation and greater coverage. Even though that MDA experienced a challenge, there was a polio outbreak in some parts of Ghana, so it delayed, and we're expecting lower coverage. But because of the approach we used, the Leave No One Behind approach, we actually had higher coverage. And then the CDD, who actually decided not to do the treatment, one of them decided to agree and start the distribution again. Next slide, please. Thank you. So there are challenges, and I think one of the key challenges we have is because Leave No One Behind is still new, the concept is new, we still need to do a lot of advocacy within our major partner, the Ghana Health Service, at the various levels to get people to really appreciate it, and also help people to, have that change of mindset and begin to take a leading role in the implementation of Leave No One Behind. There is difficulty in monitoring of the implementation at the various levels. The strategy is available, but when people are implementing activities at the various levels, especially the subnational levels, it's always not easy to get them to monitor the process. And there's poor feedback generally on the Leave No One Behind. As we submit the tools to the subnational level, we expect, feedback. If a district is starting an activity, for example, they are supposed to complete the checklist and then submit it so that we actually know what is happening. But this doesn't always happen. We've learned some lessons. One of the key lessons is that having the right tool is key to systematizing Leave No One Behind in projects. You need to have the right to be able to do that. And then we can increase mass drug administration acceptance and coverage if we allow community leaders to lead in the community mobilization. Thank you very much.
Thank you, David, for that really interesting presentation on some of the experiences from Ghana. And also thank you very much to all our other speakers in the session, and also for the participants for their engagement with the questions in the chat function. Some really important points have been raised, and we look forward to discussing these a bit more in the breakout groups. So we will now move into the breakout session. Carlos, just next slide, please. There will be 4 breakout groups, and each breakout group will be led by one of the speakers you have just heard from. The session will last for 30 minutes, and the online mapping tool, Fun Retro, will be used to map out and explore the operational and contextual challenges in embedding a Leave No One Behind approach into NTD programs by answering the 4 questions you can see on your screen now. Following this session, we'll come back together as a group for a short conclusion and closing remarks. So once we break out into these groups, the session leader or the person supporting the session will enter the link to the Fun Retro board using the chat function in Zoom. You'll just need to click on this link to access the Fun Retro board and to participate in the session. So without further ado, Claire, can we please move into the breakout groups? Thank you. Brilliant, thank you. So thank you all for your participation and engagement during those breakout sessions. I hope you found them useful. Before we close, we've got a few minutes left. So just to summarize the breakout sessions, I'd just like to ask the speakers for some highlights from each of the breakout sessions. So firstly, if we consider the first question that was asked, What are the major challenges people face in embedding Leave No One Behind approaches? Tracy, if we could come to you first, what were the most popular responses participants in your group gave to this question?
I think, if I can recall, it was around lack of knowledge and experience in the sector and the need for training capacity building.
Okay, thank you, Tracy. Yeah, similar themes came through in the group that I was part of as well. So for the next question, what approaches have you tried? Carlos, could I ask you to summarize some of the key examples that came through from your group?
Well, in our group, we didn't really have that many examples about the approaches tried. I guess that Tracy's point about the lack of experience is salient, at least in my group as well. People were mentioning mostly about trying to make sure that marginalized communities were involved in planning activities and other type of NTD activities for programming purposes, which is a way of listening to their voice and ensuring their participation.
Oh, thank you, Carlos. And for the third question, some of the examples of successes and what was working well. Anita, could you give some examples of what came through in the breakout group you were part of?
Yes. For us, some of the examples is, we have so many examples. We had recruitment of male and female CDDs peers in our community to ensure gender differences and inclusion of PWDs and minority group MDA planning and implementation. Then we have things around community management for election where we also support the caregivers, the training, and also provide transportation to the patients from the community to the health center services. These are some of the examples of success that works.
Oh, thank you, Anita. And finally, for the final question, David, what strategies did your group suggest could be adopted going forwards for that final column?
Thank you very much. So in my group, the key thing that came out is that we need to use champions going forward. I think the popular one was the use of persons with disability and people affected by MDA to actually lead the process of the Leave No One Behind. And then we also concluded that we should consciously make effort to embed Leave No One Behind in projects.
Oh, thank you, David. Yeah, and I think that's something that came through really clearly in the group I was part of too. And that phrase that was given at the start, nothing about us without us, seemed to have came through it really clearly. We can't consider programs without considering the people they aim to target as part of the planning and implementation of the programs. So before we close the session, I would just like to thank all the speakers, the facilitators who have supported the session, and the MYT team, and also the attendees for your participation and engagement throughout the session. Any questions that have yet to be answered by the speakers, we'll continue to respond to these using the chat function. So please go back to the session and check these if you haven't had a response to your question. So many thanks for your attendance, and please do enjoy the remainder of the conference. Thank you for taking part in our session.